So good afternoon, everybody. Welcome to the Women and Bleeding Disorders session of today. Just to introduce myself, my name is Rochelle Winnikoff. I'm a hematologist at St. Justine Hospital in Montreal. Nice to be in my hometown. I'd like to introduce the other moderator of the session is Elizabeth Fauvel-Benoit, who is the nurse coordinator of the Women and Bleeding Clinic at St. Justine Hospital. So part of our multidisciplinary team and probably the most important person in the team. So with no further ado, I'm going to introduce our first speaker, Dr. Michelle Shullsburg. Dr. Michelle Shullsburg has received her MDCM degree and residency training in internal medicine at McGill University, and she completed additional postgraduate training in hematology at the University of Toronto. She has also completed a research hemostasis fellowship in Toronto. She has a Master's of Science from the University of Toronto in clinical epidemiology and healthcare research. She's a clinical hematologist with a focus on bleeding and is the medical director of the coagulation laboratory at St. Mike's Hospital. She's also the co-director of the Hematology Oncology Clinical Research Group. Her research interests include hereditary and acquired disorders of hemostasis. She's currently involved in the study of prediction tools for perioperative bleeding, the appropriateness of coagulation testing, and bleeding among women with inherited bleeding disorders. So I invite Michelle to the microphone.
Thank you very much. It's a real pleasure to be here, and I thank the organizers for inviting me, and specifically Rochelle for the personal invitation. So I'm here to talk about, are there access to care issues for women with inherited bleeding disorders? These are my disclosures that are relevant to this talk. I think the most important disclosure is that I have a clinical and research focus on women with bleeding disorders. So we're going to go through the impact of inherited bleeding disorders on women, highlight the knowledge gaps surrounding the lived experiences of women with inherited bleeding disorders, discuss patient perceptions of access and barriers to care, and also the impact of bleeding disorders on their lives. So women with inherited bleeding disorders often experience diminished quality of life and disability, especially through their reproductive years. And that is because heavy menstrual bleeding is the most common symptom. It affects up to 93% of women with inherited bleeding disorders, so it's essentially everyone. And it results in important consequences such as iron deficiency, with or without anemia, fatigue, diminished concentration and productivity, all of these things which impact quality of life. I'm here to talk about social determinants of health. So these are social factors and physical conditions of the environment in which people are born, live, learn, play, work, and age that affect a wide range of health, functioning, and quality of life outcomes and risks. So this includes experiences of discrimination and historical trauma. And social determinants of health are responsible for most health inequities. I'll give you a relevant example. So iron deficiency anemia affects women most commonly, affects individuals of African race, and also affects individuals of lower socioeconomic status, and that's because iron-rich foods are expensive. And so these are social determinants of health, which translates into a mismatch between who gets iron supplementation and who needs it. In my personal opinion, iron deficiency anemia is a public health, equity, and social justice issue. So what about social determinants of health in women with bleeding disorders? So there has been concern and discussion that women with bleeding disorders are relatively underdiagnosed and maybe even have a delay to diagnosis. So why might this be? So there's normalization of bleeding symptoms, and this may or may not be related to health literacy. And so oftentimes if a woman is experiencing heavy menstrual bleeding for her entire life, she's not going to be capable of identifying what's normal versus abnormal because she only knows herself as a benchmark. There's also stigmatization of bleeding symptoms, especially vaginal bleeding symptoms. It's not something that women want to talk about even to their best friends, so they may not feel comfortable speaking to their healthcare provider about it. There's also lack of healthcare provider awareness. So there are many people that don't know how to have an effective conversation about heavy menstrual bleeding. And so it's important never to leave the conversation with, do you have heavy menstrual bleeding? Because it invites bias by the way that you're framing the question. You just need to ask, tell me about your periods. And there's often a lack of referral to hematologists. There's generally referrals that do occur to gynecologists, but very rarely to hematologists. So what kind of evidence does exist? So there's been a little bit of qualitative research in hemophilia carriers that indicates that they may experience dismissive healthcare provider attitudes, and that there may be ignorance around the significance of hemophilia carriership. And what about patients with rare inherited bleeding disorders? Again, this is also a tricky patient population because the epidemiology itself is not well established. We don't even really know that much about it and how common it is. Lab testing can limit the diagnosis. Not every lab has the same ability to test for the same rare disorders. And there's also limited information around adequate management. So all of these things can affect women. So Dr. Sumeda Arya, who's here in the audience, is a resident working with me. She's an internal medicine resident now, and she wants to become a hematologist. So she has a profound interest in social determinants of health. And because of this, we said, well, wait a second, let's just take a look at the literature and conduct something called a scoping review. So a scoping review is essentially a very explicit way of doing a literature search and then describing exactly how you're doing the literature search. There are many different levels of doing that. There's something called a scoping review, a systematic review, a meta-analysis. When there's basically no evidence, you do a scoping review because there's nothing out there. So that's what we did. So why would we do this? So we know that in general, that early diagnosis of bleeding disorders is critical for managing care effectively and avoiding complications. But it's unclear whether knowledge of women's presenting symptoms translates into effective early screening and specialist referral. So this led to our scoping review question, which was, do women with inherited bleeding disorders experience barriers to receiving care and/or diminished quality of life? So our methods were essentially very, very explicit. We had to have 2 reviewers going through the abstracts and then deciding which ones they would review in full text. They had to go through which ones they didn't agree upon, whether or not they should include it or not. And then they summarized the findings. And we're summarizing the data in a descriptive way because it's entirely qualitative in nature. So what did Sumeda find? So when she looked up using a variety of different information sources, access to care for women with bleeding disorders, 526 abstracts came up, 12 of which were focused on women's health, with only 2 that evaluated potential barriers to care. And absolutely no studies have explored these women's lived experiences or perceptions around access to care. So this led to a study rationale. So not only were we going to finish the scoping review and publish on that and say, hey, there's no data out there, we need more studies to evaluate this. But we took this further, and she and I decided to develop a small research program to answer these questions. The second study was a qualitative study of patients. The third was a survey study of healthcare providers. And then the fourth is a survey study of patients. So let's talk about the qualitative study of patients, and Sumeda is going to be presenting in detail the healthcare provider survey results tomorrow. So the objective was to understand women's lived experiences with inherited bleeding disorders and their perceptions around access to care. And that was Sumeda in the picture. So our method, so of course we got Research Ethics Board approval first. We had a group of hematologists, patients, a really important qualitative methodologist named Katie Dainty, and we developed a semi-structured qualitative interview guide. And we would include patients who were adults over the age of 18, those who spoke English, and those who had the diagnosis of a bleeding disorder. And then Sumeda conducted 9 interviews that she recorded, and then went through a special analysis called En Vivo, which allows for descriptive thematic analysis. So she pulled out relevant themes, and she continued conducting these interviews until she reached something called theme saturation, until she felt that she was no longer hearing anything new. So here are the preliminary results. So these are on 9 interviews with 9 women. The median age of women was 31 with a range of 24 to 70, 2 of which had BWD, 2 hemophilia A carriers, 2 hemophilia B carriers, 3 with platelet dysfunction. And these were the themes that came up. So I'm going to go through one by one. So the first one relates to diagnostic factors and uncertainty. So there was a lot of variation in the diagnostic basis. So many patients had different types of tests done. Patients had different symptoms that led to the diagnosis. Some may have presented with a family history, which is what led to their diagnosis. There was also difficulties in differentiating normal versus abnormal symptoms, in large part due to it being hard to define what's normal versus abnormal vaginal bleeding, and certainly women who experience heavy menstrual bleeding their entire lives are also much less likely to identify postpartum hemorrhage. There's also challenges with diagnostic labels, right? Do we call her a carrier? Do we say she has mild hemophilia? What do we say? And there's also diagnostic uncertainty and lack of understanding. So I'm sure that many of the hematologists in the room have patients that we retain in clinic who have bleeding disorders, NYD. We know that they have a positive bleeding history. Many of them have positive family history, but our tests results are all negative, and that's a real challenge. So here are some quotes. I'm unclear of exactly what it is because the doctors are unclear of exactly what it is. I have a platelet dysfunction, and it's like unidentified and unspecified. I don't know what's wrong with my platelets. It's fair. The next theme is affected family. So some of the patients described being symptomatic but not having any diagnosed family members, which may have called into question the diagnosis. And there's also a variety of intensity of the bleeding symptoms. So not just the intensity, but the type of bleeding symptoms experienced within a family. And so that doesn't negate the relevance of the patient's personal history. And here are some quotes. We know that it has some sort of genetic component to it because my mother and myself and my 3 sisters all have it. And then my niece also has it. So we know it's within the female link, and for my mother because my brother and my 2 nephews don't have it. We've also had experiences with bleeding in both sides of our family, like on my mother's side and on my dad's side. So I don't know where it's even originated from because my grandmother is not diagnosed. What about bleeding disorders' effect on life? So again, the theme of the variety and intensity of bleeding symptoms, a negative impact on one's life, leading to a sense of feeling different, fear, worry, and enforced limitations. The woman's concern about the effect of her bleeding symptoms on her family members, which I think is really interesting. And also there can even be a positive effect on one's life, so a sense of affiliation and community with things like CHS. And sometimes that even leads to a sense of empowerment. So it's really, really important to have strong patient advocacy groups. It makes a difference. So when I'm on my period, I can't go to school. I will wake up with my sheets soaked in blood. It was scary. It was hard to look at my future, like I didn't even see if I had any future. What about treatment plans? So this was another important theme that came up. Our patients talked about as-needed treatment for abnormal uterine bleeding, the need for iron supplementation, and family planning and pregnancy. So these were the concepts that came up as being very important to all of the women that were interviewed. So my period is supposed to bleed, let's say 4 or 5 days. So after those days, let's say 8 days maximum, I have to take the PRN cyclocapron because it's not normal to bleed after those days. If I'm having surgery, for example, probably a half an hour before I went to the OR, I would get IV DDAVP. So there's a lot of awareness of the importance of treatment. Another theme was experienced barriers. So an important concept here is that healthcare provider dismissal of symptoms resonated. Lack of healthcare provider awareness. Geographical barriers, that was a big one. And perceived gender-specific barriers. And I gave them my Factor First card, which was useless. I may as well have given them my Air Miles card, the way that they looked at it. Which is so depressing to hear, right? And then another theme was access to care factors. So access to clinic and lack thereof, access to treatment and lack thereof, self-awareness and self-advocacy and advocacy by others. And they were saying, oh, well, you're just a carrier. I said, well, if you've got an hour, I can educate you on that. So these are the preliminary results, the themes that came out of the qualitative research that Sumeda conducted. And now let's move to the survey of the healthcare provider. So this was sent out to members of the HCDC, members of our nursing group, members of our physiotherapy groups, with the objective to determine whether healthcare providers feel that certain populations experience delayed diagnoses or impaired access to care. Now, Sumeda is going to go through this in exquisite detail tomorrow at the AGM, and I encourage you all to attend. But I'm going to give you a slight teaser as it pertains to access to care for women. So this is one of the questions that was asked. So this, again, is from the healthcare provider's perspective. Among patients with bleeding disorders, which group do you perceive to experience greater diagnostic delays? And those that were most important, milder symptoms, heavy periods being the only symptom, women, and carrier status. So these are some of the most important answers that were coming up. So as clinicians, we're identifying that there's probable barriers to care for these women. Another question that was asked surrounding perceived decreased access to care. So Sumeda's going to go through this in detail, but one of the key findings here was actually geographical barriers. But another one that came up was women with inherited bleeding disorders, including symptomatic carriers. So, in summary, women often feel, and may actually be, not just from the patient perspective, but also from the healthcare provider perspective, dismissed by healthcare providers. Women with inherited bleeding disorders often feel unheard or misunderstood, and this can lead to a cycle of disempowerment. Healthcare providers identify being a woman, having milder symptoms, having excessive vaginal bleeding as the predominant symptom, as all of these leading to greater diagnostic delay and diminished access to care. We believe that by better understanding patients' lived experiences and acknowledging social determinants of health, that providers can be more comprehensive and provide more thoughtful care. So the next steps, Sumeda is going to complete the nationwide patient survey, which has been launched with our wonderful team, which includes Pam and David, through CHS. And we're also going to be conducting qualitative interviews with men. So we were just presenting the interviews with the women. We'll, of course, do it with men as well. So I'd really like to acknowledge Sumeda Arya, Pam Wilton, David Page, Lawrence Bauma-Fisher, Georgina Floros, Rochelle Winikoff, Jerry Title, and Katie Dainty, who's our methodologist. And I thank you all for your attention.
We actually have time for 2 questions. Maybe I'll start off. So if we can recognize from this that there are barriers for women to have the care that they need. The question is, which area of that you've identified do you think would have the biggest impact to work on? So for example, if I think of the geographic issue, that one's a hard one to tackle. If you think of menorrhagia only as a symptom, it may be more amenable to change. What is your view on that?
I agree.
You agree?
I agree. I agree. I think that, heavy vaginal blood loss, whether it just be heavy menstrual bleeding alone with or without the addition of postpartum hemorrhage, I think there's a lot of unrecognized PPH, a lot, because, so women often say, oh no, it's just heavy menstrual bleeding. But then you say, well, so how was it, how did you bleed after childbirth? And she says,
like my menstrual period.
It's fine.
Yeah.
So once you quantify her menstrual period and you go back and say, was it like that? And then she'll say, actually, it was a bit worse, but, and we know this from other studies that were conducted, other qualitative studies that were done last year by Heather Vandermeulen, where she found that women often normalize vaginal blood loss. So I think that working towards that is probably step one, and probably really engaging our gynecology partners and
a little bit more,
making them more attuned to the potential for underlying hematologic contributors.
Paula.
So Paula James from Kingston, Ontario. Congratulations, Michelle and Sumeda. That's really important work. It's sort of the same question, but maybe from a bit more of a general perspective. Those of us who look after these women and these women themselves who are suffering, sometimes it feels like we're banging our heads into a wall and trying to get people to understand the depth of the problem, which was just explained so clearly. So this is totally unfair, but so how do we fix this?
Oh gosh, Paula. Okay, so I'm gonna put it back into your court. But I think with things that you're already doing. So I think that
that was not what I intended you to say.
But honestly, I think that through knowledge translation and exchange. So with things like Let's Talk Period, with we need huge public health campaigns, and I think that partnership with CHS is critical in that. I think that we need to start by educating the patient, the woman herself, right? If she can't recognize what's normal or abnormal, we're never going to see her.
Yeah, I think you're right. I think it's public health.
Yeah.
And speaking to that last point, that would help the geography issue,
right.
Whereas other ways of trajectories to tackle it might not. But self-empowerment is the way to bring those patients that are far away. Yeah.
Absolutely.
So with that, thank you very much.